For the terminally ill, there comes a point in life when cure becomes impossible, but care is. We're at St. Joseph's Pain and Palliative Care Center in 7th Mile, Chumukedima, a place founded in 2022, an initiative of Catholic Diocese of Kohima, managed by the Congregation of Medical Sisters of St. Joseph. This is a story of hope, dignity, and the people who stand beside the patients during their difficult moments in life.
And the sisters used to come at home and did the dressing. Their love and their care is wonderful.
Yate ahe piche de beshi korpora bi yate bra pa bra saigen khai laka hole be ke te kan staff kan amige pa bra saigen ite to khushi bra moi thakishe.
Praise the Lord. My name is Mary Joseph. I am from Dimapur village. I came here after my stroke in the month of October 2024. I stayed here 15 days and my stay was very much effective with sisters and their helpers. Looked after me very carefully, very nicely. Another thing, before that, in 2023, 23, I had an insect bite on my right leg and it affected my veins and it became big. A lot of blood was taken with that, and the sisters used to come at home and did the dressing. Their love and their care is wonderful.
I'm doing some of say. I'm doing Palliative Care the Ato 2020 or the Genesis Paracha. I'm doing Chacko or to 2018 March me 8 in Hoja. Quality Manukum made about night to bar Itacha. Yeah, to more to first business. I mean, 80 part to 80 part to 2 years up Hoja. It had a be second bar. How much now? Watching didn't Bishop of Passai. I'm the Itato fishing book in book water. Got a pay in book water. What the pay in book water. It up to call a pay. Tip Papa Casa. It more to copy Bishop Papa water. Second bar or second bar. Water in more can be, but I could take to take care. Kiki can take care, conserve, comfort, or caring. Bishop Papa said, the Pamoto, it is a gato, she had a poison. So, Moto, it is the taken upon one night. Mokan Takana. Takano, and I am to Takana, a month out. He keep him. It penny Kiman at a so pass as a subcon post so pass as a most can be peace, Papa said to care. Kiki hoping moto man American about my neighbor, moto eka ingin apa apa. Gimana sekan kan sabkan iki giman ai aja tak kama isi apa saya teke kiki ke teke ko do mundo nai tiba kumba kode ba saman ka nai kode ijepe itu SPPC isi bahasa mungkin tu pada tu mau pada tu di bangki utak kod nanda hoca gimana so hoca ben insyu hoca pada tu mau tu kota bi nangga im aja dah ba hija api tu kota bi kuasa mau tu hija kina Baba puasa, lebe ekibi geta. Itu dah kamu tu ipisi pa. Itu kita itu gimana bahasa dah. Itu kiki pesi gimana aja pi papa empu begini jasa ke. Coba itu kata pisi bahasa.
Ami yate ahe tu June date 6 de sister khan aiken pukhishe aro ami la bimar tu spinal cord te tumor inika thaki kena ko debi chawole na pari kena cord te thake tu sister khan aiken loise itu para yate ahe piche de beshi khor para bi yate para sai kena khai laka hole be ke tai khan staff khan ami ke para sai kena ite to khushi para moi thakise aro moi tu yate ahe pichete amila kaubi alop to improve hoi kena chaise tai khan khai laga ki ami khan side de sob staff manu ami ke morom kori kena nijur amma nishina ami ke sai kena itu para moi beshi khushi para yate thake to boi kena thakise.
At the beginning, how we came into contact with the sisters is that my mother had, in 2022, she had diabetic neuropathy. And from a small insect bite, it has developed into a big wound, and lots of debridement has been done. And the doctor at the hospital, he suggested to amputate my mother's leg. But I had confidence. When I heard that my mother's leg has to be amputated, I was so distressed, because even with a small wound, she was suffering so much, and then I could not think of her leg being amputated. I could not think of her suffering so much. So I thought of coming, when at the hospital, I thought of getting discharged and coming to the palliative care, because I had confidence that sisters will do, in their own way, they will be able to take care of my mother without her leg being amputated. So in 2022, in the middle of the year, maybe June, July, we got her discharged, and then we came to the palliative care center. So since my mother cannot walk, the sister used to come to our house. They would do home service, and then they used to come by their own vehicle, bring all the aids, all the instruments that are needed to do the dressing. So they will come and then take their time, according to the comfort of the patients. They used to do the dressing and apply medicine according to her wound, also for regrowth of her muscles, or for the for the not so good, or instead of debriding, instead of cutting the not so good skin or muscles, they will do the apply medicines, or if at all needed, they will do the dressing, the cutting and all. Otherwise, they don't simply, anyhow, they don't do the dressing. They have lots of patience, and they're never in a hurry when they come to visit us. I know they are so busy running a big institute. They have lots of commitments, lots of work. But then when they come to visit, they take their time and then they look after my mother. So not only her dressing up her wounds, but also of her mental and emotional support, prayer support. So it's of an immense relief that I get from this institute. And I would like also appreciate the sisters, for their willingness, for their open-mindedness to take care of patients any time of the day. When I go for work, and if my mother needs an attendant constantly, so when I'm busy, when there is no one at home to take good care of, especially when she's not so well, I used to bring her here to the palliative care for daycare. And I don't have any worry. Once my mother is inside this palliative care, they will take care of everything. So I can go for my work peacefully. And then at the end of the day, when I'm done with my work, I come and pick her up and then go home. So it's a huge relief for us, like having family members being in a palliative state where they need constant medical attention. They cannot be admitted in the hospital, nor like that. But then they need constant care at home also. So sometimes when that is not possible, palliative care center is the best alternative that can give us the family members and even the patients also, to get their illnesses, and also to have the mental, emotional and prayer support. And also one thing that I'm so grateful to the institute, to the sisters also, is that they come for treatment, they come with their own vehicle, they apply their own medicine and so many things related to the treatment. But they never asked a fee as such. You give this much, or you have to give us something. Whenever I ask Sister Prina, she used to say, why do you want to ask that? If you can, you give, otherwise it's okay. So that way also it has helped us as a family. Sometimes there are lots of financial constraints also, and we are not able to, if it is in the hospital, somewhere we have to find and pay the bill. But in regard to palliative care, it's not like that. So whenever we can, in whichever way we can contribute in cash or kind or other services, they are, they are so willing. Even if we are not able to give them back for the treatment that they have given, they say, no, it's okay. God, let you pray that God will bless us. That is what sisters, they used to say. So I'm so grateful for the institute that, they have this grassroots level, to deal with people in the grassroots level, understand their problem, and then give the best of the services also.
Well, the Diocese of Kohima is here as such, is working here from 1973. It became a diocese here in Nagaland. So ever since, the Catholic Church has been working in various fields. Two of the most important area where the church works is in the social field, education and healthcare. So, like as you know, a number of schools and colleges are there already. And in earlier days, before the new government regulation came, that only doctors could be prescribing medicine and doing certain kind of medical interventions. Our nurses in the villages used to do a lot of work taking care of the sick. Now that has been reduced because of certain legal implications. So because of that, we said what are the areas where the other agencies and also the government is not able to reach out. So we did a lot of survey, one based on our own experience working in practically all parts of Nagaland we have been working. So one of the things that we realized that taking care of the terminally ill people is an area which is not at all covered by anybody. The immediate reason why we got into this is we work closely in connection with the referral hospital, CIHSR as it is called. So while discussing with the Dr. Sedavi, one of the things what he said is that they have a wing for palliative care. But then being a hospital, there are many limitations when, especially when a family comes with an elderly person or terminally ill person, there are many limitations. So we said palliative care will be the best answer to dealing with the issues of terminally ill people. To make it simple, like suppose someone gets terminally ill, one thing is old age. The other one would be a stroke or cancer or an accident where the person needs medical care but does not need to be admitted in the hospital. So when a person is admitted in the hospital, one thing, the expense involved in it. Secondly, the family members to be part of that. So the same care can be given in a setup where the person receives adequate, affordable care. At the same time, the quality of the care is not diminished because the hospital is not there. So that is the reason why we said we should start this palliative care, which is something very essential today with many people, elderly people, terminally ill people. The numbers are increasing. So that is the reason why we went into this.
The mission is personalized, compassionate, total care.
Yeah.
What does total care require from a management perspective that a regular hospital might not provide?
Okay, that's the second part. What a regular hospital cannot. A regular hospital is meant for dealing with illness. Now, palliative care is not only dealing with illness, it's also dealing with the dignity of the person. Of course, the hospital also takes care of the dignity of the person. When someone is terminally ill, what the person feels in the first place is it's all gone. Life has not much of a meaning, nothing can be done about it. The second thing that the person feels is that I have become a burden to my family and to the society. So the total care is something that we are telling that you are a sick person, you are suffering, but you as a human being is equally valuable when you are productive or when you are working. You are even now important to us, to the society, to the family, to the church. This is something hospital setup cannot give, because a hospital will have 100 people coming, 200 people coming, then there are regulations. This is the time you can come in, this is the time you cannot come in. And there are various administrative issues related to a formally set up hospital. Besides that, there are also other regulations related to health care. Palliative care deals from slightly different perspective, does not come under all the regulations which a hospital will have to take care of. So the advantage that we are here is that we give health care in a family setup where the family members can come, where the other people are there. And of course, as you are aware that this is something that we run what we call no bill. Whether the person can pay or not, we don't ask. If he can pay, you pay for your expenses. If he can support one more person, if your family can, you do that. We are always welcome. But just because you don't have the financial resources, your health care will be in safe and sure hands. Okay.
Palliative care is still developing in Northeast India. What gaps is the state healthcare system is SJPC specifically trying to fill?
Yeah. As we said, palliative care, like many other things here in the Northeast, not only in the Northeast, many parts of India, it's a developing thing because palliative care, usually what people understand is it's about taking care of some old people, old age home and things, or it's something like that. But the whole understanding of palliative care is simply this, that someone who is terminally ill is equally valuable for the society. And this is something that is not easily understood by everybody, only very few people understand. The other aspect of this is that, especially with regard to elderly people, we know that especially in the Naga society here, and it's there in many societies. Suppose my father is very sick, and for various reasons I cannot really give 100% care for my father or mother or somebody. At the same time, I find it difficult to admit that person in an institution because the society will say, chadi diji. No, this stigma attached to institutionalizing a person who need care at the terminal ill. This is a very technical, little bit of a crucial thing that many people don't understand. I want my father to feel the maximum comfortable situation. I cannot keep that person in the hospital. Even if I keep this person in the hospital, I cannot be always there. I can't afford to do that. Or I may not have the resources to do that. At the same time, my father or mother, whoever is this person, is suffering, and I cannot also see that and feel good about it. Now, when the society does not understand that I cannot care for this person, I don't have the skills, I don't have the facility, there is an institution that can take care of it. But then the society will look at it as something not so good, just like that. So this is the reason why we are saying that this is something that is developing. It is not because I don't like my father or I can't care for my father that this will be a better place, you will get better comfort and better care. Equally good care can be given in a situation like this.
This is about bill policy and sustainability.
Yes.
Okay. SJPC operates on a no bill policy.
Right.
From an administrative standpoint, how do you make free quality care sustainable long term?
Yeah. It's like this. It's like many things that the church does. It is one day at a time. Till now, we have not suffered seriously because we did not have. Somebody or the other comes. Of course, there is certain amount of basic support from the church. Like the church will take care of, at least they will ensure that the food will be there. There are hundreds of people who come in and give maybe something, maybe a bag of rice or something like that. We keep on getting that. And relying on the providence of God, we say, this is the way that it should go. It is for the simple reason that those who can afford, they can support their own plus somebody else. But so that another person who does not have these resources should be able to be helped. That is one. But then our experience has shown that it is possible for us to continue with a service like this, and we hope to continue, and that is the reason why we are asking for people's associations, churches, individuals. We will also try to access the government or corporate funds if possible. So we hope that this will go, and in other parts of the country, things like this do happen. We hope that it will happen here as well.
What percentage of your funding comes from individual donations versus institutional or church support, and how has that mix changed since 2022?
We have not made a serious, I mean, to answer is a bit of a technical question, what percentage? Just looking at it very generally, we could say that about 50% of the funds come from certain sure sources like the church support, some of our institutions. There are already some individuals who have said every month they will pay 10,000, 20,000 like that. So that way we get about 50% of the running cost on a sure basis. The other 50% keeps coming every day, one day at a time it comes.
Beyond money, your brochure says we need your support.
Yes.
What non-financial resources are hardest to secure? Trained staff, volunteers, medicines, or community trusts?
Yeah, all the things that you have listed just like that, food materials, medical, like medicines, things related to the thing, equipments here, because as of now we have 20 beds. As the message goes around, there will be more people coming, and sometimes we had cases where we could not admit. It's very difficult to say when people make a request and we have the space for that. So we would like to take this, develop these facilities, like train volunteers. As I said, we can train volunteers in every family, starting with the family, wards, churches, social organizations. If they can take care of their own family people or the people within that locality, in fact, many places they do that. It makes a social movement. It is not just an event that is happening here, but it makes a social movement. That is something that we would like to make things happen here. Finance, of course, is a smaller part that will keep coming and going, but as people get more and more educated, knowledge about the various aspects of the dignity of life and healthcare, I'm sure this is going to make a big difference in the society.
Tell me about your awareness and training programs.
Yes.
Are you partnering with medical colleges, nursing schools, or the state health department?
When you say the partner with, of course, the only the groups like organs with which you are directly partnering is with the CIHSR, that is a referral hospital. We have an MOU with them. It's the one. We have not had any formal partnership with others, but like the colleges like here, the Mount Mary College, they come quite often and they are quite happy to be part of this. The Patkai Christian College, they had sent their students. So, but we have not made a formal agreement with them, or we do not have an MOU with any one of them. The only group with which we have an MOU is only two. One is CIHSR, the other one is Nature, the Northeastern Social Research Center, Nature. So these are the two organizations with which we have a formal MOU. Others, it's a free collaboration.
What policy changes at the state or national level would make your work easier? For example, around opioid access for pain management or palliative care inclusion in health schemes?
Yes, in fact, I think there are, we have not serially studied, what are the possible things that the state can give. Only from the experience of other states, like I know some states allot fund to local bodies, like in Nagaland it could be like VDBs for palliative care. Like in the south, in Kerala for example, they allot certain amount of fund to the panchayat. So those terminally ill cases in the families, the family members can access maybe medicine and other things through that. So I don't know if Nagaland can ever think of that. I was told by the former director of social medical family welfare that Nagaland did not have a separate fund for palliative care, but she made an effort to include that, I think, last year. We have not pursued how far they have succeeded. What I would suggest is that the government of Nagaland, the Department of Health and Family Welfare can see what are the ways in which funds can be accessed, especially from the central government for promoting palliative care. It is possible for that. And the state government, I believe there are funds available under various names. So whether they can be accessed, of course, it needs more serious study. I wouldn't like to make a comment on that otherwise.
Do you see SGPC as a model that could be replicated in other districts of Nagaland? What would it take?
Yeah, I would not say this is a model. Of course, yeah, in a way it could be called a model because what is applicable here in Dimapur may not be applicable in Tuensang or in Mon or in Wokha. But the basic things that we do can be used. So people can learn and see how it can be done in other parts of Nagaland. But what we are saying is that we can always train people to take care of sick people, terminally ill people in the families or even in small institutions. So from there the message can go across to other people. To set up a system like this in other places, yeah, this is a viable model, that I have no doubt about it. But it calls for infrastructure, which means investment, quite a bit of money and all that. But it can be. In fact, this is not anything new. We have done it learning from what people do in other parts of the country or other parts of the world. So it is possible for us to do that as a model. But I would not say that just take this one and do the same thing in another place, because the need of that place would be different from what is in Dimapur. What is possible in Dimapur may not be possible in some other place, and it may not be even required. That is the thing. If they are able to take care of the people in the families, you don't need an institution to do that.
It's been 4 years since SGPC was founded.
Yes.
What has been the most unexpected challenge as director, and what has been the most rewarding success?
The most unexpected challenge means this is something new for us, because we have stayed in institutions like this and have some first-hand experience. But otherwise, we have none of us who are involved in it have done it directly. We only have seen other people doing, and we got some training. So everything that we did was a learning. Through trial and error, we did various things, whether it is about taking care of the sick people, getting the volunteers, finding finance, getting equipments, getting public support and all that. So it has been a continuous learning for us. So those have been the challenges, because it's still very new for us in the thing, because as I said, none of us have been directly involved in running a palliative care center. So that way it has been always a challenge. The most satisfying thing is we had cases where people was brought in on the stretcher, but have gone back to their jobs. There are people who have gone back to their studies. There was a boy, of course, he is not around here now, who was a drug user, and his family threw him out because he had practically possibly spent everything on the family. And he was thrown on the roadside. Some neighbor called us because that lady had the contact. We went and picked him up. He was brought. We thought that he will not survive many days. But then 6 months later, now he was here. He got well. Now he has gone back and he got married. He is working, I think, somewhere in Bangalore or somewhere, I believe. So that is one of the most satisfying things. The other one is the kind of cooperation that we get. Like I would again mention CIHSR, Referral Hospital. Dr. Sedevi has been a great, he's a man with a lot of interest and also knowledge in that field, and they have been very helpful. We continue to learn through that. And the churches, various organizations, the media has been also very good to us. So these are all highly satisfying things for us.
Looking ahead 5 to 10 years, what is your roadmap for SPPC? Are there plans for expansion, specialization, or research?
Yes, all these areas are needed. As we said, this is something new to Northeast. Therefore, expansion, yes, definitely it is needed. And then, there can be what we call palliative hospital. Right now, suppose somebody becomes critical, we have to rush them to another hospital. We can have, let us say, certain advanced facilities for cancer, for example, and some of the other illness which we have. That is the thing. So we would like to expand this one into a better facility. Then, I was telling earlier, definitely collaboration with CSOs, faith-based organized churches and all that, because they are the people who are able to take this one forward, and because they are the people who are directly in touch with the families directly. So we would like to do that in a very big way.
Last question. If you could ask the public for one thing today, besides donations, what would it be?
Oh, if we could ask one thing from the society is, come and visit this place, keep coming and looking at and knowing, because someone who is terminally ill, bedridden, is always looking at the only thing that person sees is the ceiling or a few people who move around here. When you come and talk to that person asking, Keneka, saying, how are you? I think that gives greater satisfaction and consolation to that person. So that is the first thing that I would ask people, come and get to know this place. Then, of course, other things will fall in line.